Good morning, friends. Today we are going to learn how to treat the patient with irritable bowel syndrome. We know that this is a very common disease, and in our OPD and routine practice, we are getting a lot of patients with the disease, and the patient is quite anxious and anxious about the disease as it is mostly in the chronic form, and there are many options available in the market, but as a routine practitioner, as a general practitioner, usually we don't know that how to go through the practice, how to advise the patient, how to counsel the patient. So we will see every aspect one by one. So we will go through the definition that we are going to diagnose the patient that they are having irritable bowel syndrome. So by the definition, this is the definition from the Harrison, and it's the standard criteria we are going to follow. And by the definition, the patient must have recurrent abdominal pain or discomfort. Patient might say he is having pain or any kind of discomfort or bloating at least for 3 days per month. Means in a month he must have symptom for 3 days, consecutive 3 days, and these kind of month, the affected month must be at least 3 in a year. Means in a 1 year of duration, patient must have the symptoms for at least 3 months, and in 1 month for consecutive 3 days. So if the patient having these following the fulfilling this criteria and any two or more of the following, which means if he or she feels that there is improvement in the symptom after the defecation, and there is a change in the frequency or change in the form or appearance of the stool. So how the patient will come to you in the OPD and how he will complains you. Let's set an example. Let's say if 30-year-old male, he come to you and he is saying, sir, I am having very difficulty in passing stool. Sometimes I have very hard stool that I have to take it out from the finger, or sometimes I have broken stool. Means this stool is not formed stool, it's broken into pieces, and when I pass the stool, I feel better after the defecation. I feel better after defecation. So this is the typical complaint patient is telling you, and the duration he will tells you since 1 or 2 year or 10 to 20 years like this. So from the long duration, from a very long period of time, the patient is feeling these kind of symptoms. There is a increase of frequency, means when he feels improvement after the defecation. So the tendency becomes to go again and again through the toilet and for the defecation. After that, patient feels symptomatic better. So the consistency can be hard, can be broken, or can be watery. There is improvement and the duration will be long. So this is a typical case we are having in our OPD with the IBS. So here, so this is the patient, and now we have to categorize the patient according to the definition that in which category he fits in. So as the name suggests, IBS with constipation. So here the predominant complaint is constipation. Means when patient is having altered bowel habit in 3 days in a 3 months of period in a year. So the most of the time he is constipated. The stool is hard and there is no blood. There is absolutely no blood in the stool. The only complaint is hard stool, and very typically patients say that they have to take it out with the finger. Means this is so hard that patient is unable to strain, so he has to take the stool with the help of finger. So IBS with diarrhea, as the name suggests, the predominant complaint will be diarrhea. So most of the time patient is having diarrhea, and the stool which is passing is unformed stool. And the patient typically says that I am passing the broken stool or stool in pieces. Means he is having pieces of stool with water. So this is a typical complaint, and the patient told you, and the duration, as I already told you, will be from the 2 to 3 years or more than that. Means the duration will be in years most of the time. It can be in months, but most of the time, in most of the cases, when you see the patient, it is in the years. There another category which is mixed IBS. Means there is altered bowel habit with altered symptoms. Means patient is having sometime constipated, sometime diarrhea. These are alternatives, sometimes constipated and sometimes diarrhea. So we will categorize them as a IBS-M. These are the short form. The most of the gastrologists they use in the prescription IBS-C, D, or M. There are few patients which is comes in this category, that is unclassified IBS. Means who meets the diagnostic criteria. Means they have IBS by the definition, but they don't fit in any category. Like they don't have they have constipation diarrhea, but the frequency is not set. Sometimes for the 2 years, like for the 2 years of time they having constipation, then next 1 year they having diarrhea. So we can't say this is constipation or diarrhea predominant. Then we classified them into unclassified. So these are the basic four classification of the IBS. We see next, we move on to the diagnosis. So, IBS, there are no as such laboratory tests by which we can confirm the diagnosis of IBS, irritable bowel syndrome. The most of is the clinical diagnosis when the patient fits in definition, and this definition is known as Rome 4 criteria. So, when patient fits in Rome 4 criteria, we say the patient is having irritable bowel syndrome. We label patient as IBS, right? And yes, so should we go for the lab test? Yes, definitely we are going lab test because we have to diagnose. So we have to include the test and we have to exclude some diseases. For the exclusion of the diseases, we need laboratory confirmation. So for the exclusion, we go through the first to the routine test, जिसमें we have CBC, CRP, serologic testing we have for HIV and HBsAg. As we all know that chronic diarrhea or chronic constipation, the differential is one is HIV. If the chronic diarrhea or chronic constipation is associated with significant weight loss, the first thing we should think of HIV. The first differential which will come in my mind, in our mind, is HIV, right? So we will go for HIV. We definitely going for stool examination to see there is any worm infestation, there is any undigested food particle, so that must be examined. We are going for radiological studies for like USG whole abdomen. We can find sometimes we can find some unusual things in the sound where we might not thinking of, because there is a say in our routine practice, when you are practicing in our OPD, you think common first. First we think for common diseases, then go for the rare diseases. We never think of rare diseases at first time. So we have, and if after these radiological or any examination, we don't find any clue, then we can think of malignancy, that there are the rare. So we will think in the last only. So for malignancy we are doing in the last only. In starting we will go for routine testing. Next thing that comes in our mind is differential diagnosis. That what are the possibilities when patient came to us with these complaints? What the other diseases we can think of? Because in the clinical practice, when you are dealing with the patient, there must one thing that you have at least 2 to 3 differential diagnoses in your mind, for which you will investigate the patient and then treat them accordingly. So, first one, closest differential is inflammatory bowel disease. That is, as we all know, that is Crohn's disease and ulcerative colitis. Both of diseases are combined together as a inflammatory bowel disease. And the most striking differential point from the irritable bowel syndrome is bleeding, bleeding per rectum. So if the patient is having inflammatory bowel disease, there is some time when patient is having blood in his stool. If there is blood in stool, we never think of IBS, because in IBS there is no blood. As we know, there is no blood. So once there is a blood, we will go for IBD, irritable bowel disease. And once we came to the differential of IBD, we will go for colonoscopy, and then we will see it is Crohn's or ulcerative colitis. So very straightforward diagnosis. Once the patient came with complaints of this, as we have seen the definition, and he says that there is a blood mixed stool, then you straightforward, you go for the colonoscopy, and with the colonoscopy you can make the diagnosis. The gastrosurgeon will take the biopsy and then do it for whether any malignancy or mass also. So that will make a diagnosis of IBD. They will differentiate this is IBD or IBS, right? The next is celiac disease, that is gluten sensitivity. So gluten sensitivity is when we are thinking of celiac disease, what we have to do, just remove the gluten from the diet. We have to counsel the patient that he have to take gluten-free diet. Once he started gluten-free diet, if there is improvement in symptoms, we will make the diagnosis of celiac disease and we will eliminate the IBD. There is no IBD. This is celiac disease. And intestinal pseudo obstruction, there can be a possibility when patient have some heavy load of infestation, worm infestation, or there is some paralytic ileus which presents with features of intestinal obstruction, but there is no true obstruction. So we can think of this. Lactose intolerance and malabsorption syndrome. Yes, definitely they are the differential, because in their malabsorption syndrome also there is increase in frequency and increase in the consistency also. Both are the altered in malabsorption syndrome, and similar with the lactose intolerance when we have allergy to, when the patient is having allergy to lactose. So whenever he take milk products, he will have diarrhea or constipation. In psychiatric disorder, there is psychiatric disorders like depression, anxiety. They are the one of the differential for inflammatory bowel, irritable bowel syndrome, because in psychiatric disorder they are the precipitating factor also. As patient, when patient is having chronic depression or chronic or severe anxiety, they can lead to IBS, irritable bowel syndrome. They can lead, yes. And opposite or vice versa is also true. When patient is having IBS, they can go into depression, or they can go into depression or anxiety. They can have severe anxiety, as they might think of something bigger diseases. Some endocrine pathology also, and most common is thyroid disorders. They also presents with ultra bowel habit. We know that in the hypothyroidism, the patient is often constipated, and in hyperthyroidism, patient is often having diarrhea. So they are the differential. Some endocrine tumor also they come into differential diagnosis for the IBS, but they can be easily differentiated when once we advise the routine test, we can include the thyroid profile, which will exclude the thyroid. We can go for sodium potassium, which will exclude the Addison's disease, like this. Blood sugars will be exclude the diagnosis of diabetes. In the tumor, when we go for ultrasound, USG whole abdomen, that they might pick the some lump in the abdomen. If it is inconclusive or we didn't get any final diagnosis with these routine tests, we can go for CT scan of the abdomen, and in that case we will get the tumors. So these are the closest differential diagnosis we will get with the IBS, and when the patient comes to you, we can differentiate according to the symptoms. And for these differential, one what is the most important point we must know is the history. Where if you're good in taking history, then you can differentiate all these. So when you are in OPD and you are dealing with patients, never forget to take a good history. Now the most important part, you are routine practitioners in your area or in your OPD, and you have to initiate the therapy for the IBS. Now we are treating a patient with IBS, and the first and foremost is education and reassurance. Yes, why it is so important? Because it is a chronic disease. Since many years, patient having these problems. So what the patient will do, educated or mildly educated or low educated, I should say, the patient, he will search Google. He will search Google his symptoms. He will do Google his symptoms, and what Google will tell him or her, that he is having some malignancy and he is going to die in few years. So this is the most common problem we are facing with their patients of IBS. They usually Google their symptoms, and the Google they tell them that they are malignancy. So you have to tell the patient that this is not a pre-malignant state. This is not a pre-malignant. This will not increase the risk of malignancy. So he is fine, totally fine. The disease is totally okay and it's curable. So what he has to need, just follow your instructions. Second most important thing you have to do is diet modification. This is the most important part. Most of the mild cases of IBS, they will reverse with diet modification only. What you have to do, you have to exclude the gas producing food. We use the short form is FODMAP. FODMAP stands for fermentable oligo and monosaccharides and polyols. They are the food component which produces excessive gas during his digestion, and they create some bloating or abdominal distension, and sometimes also lactose and gluten also, which we have to avoid during the diet. So what kind of diet you are going to advise is a regular meal pattern. His meal pattern must be regular, and he has to avoid large meals. Means an IBS patient, when he is having 2 meals per day, you have to counsel them that apart rather than 2 meals, he have to need to take 4 meals per day, which must which, which must be in a small quantity, right? And the food maps which we have already discussed, they have to exclude from the diet, and they are the caffeine, gas producing food, beans, onions, celery, carrot, fruit, banana, apricot. There are number of list, a long list of food maps which we have to ask the patient to avoid. But sometimes it will very good. It become very difficult to exclude each and everything. So what we can say, just reduce the quantity, not take too much of these food. That is also sufficient. And making his diet pattern regular with small diet is the only thing. This is the only thing that patient needed in mild cases. And now, if patient is having food allergy, if you're thinking that patient might having food allergy, your patient will tell you that I have Google my symptom and I found that I am having this allergy from some allergic to some specific food. So you can counsel that patient that there is a role of allergy is very controversial, and there are no reliable tests available in the market which can exactly test allergy, that which component of food is creating problem to you. So that is, and there are also not a such test in the market that can assess each and every component of the food. So this is very difficult. Physical activity can play a very important role, and although this is controversial, but this can be improve the patient if patient is having some psychiatric disorder, like patient is depressed or anxiety, patient is working from home, and there are some personal issues with his family. That in that situation you can counsel the patient to busy his or her schedule, which will improve his symptoms. In physical activity, you can advise him gym, you can ask him to do some meditation, you can ask him to do some yoga. These are the kind of physical activity you can advise. When there is mild, apart from mild cases, when they are moderate or severe cases, yes, so you have to include the food, you have to diet modification, you have done physical exercise, physical therapy you have given. Now the role of pharmacotherapy, so you have to advise the drugs also in the moderate to severe cases. So once you have diagnosed that the patient is constipation predominant IBS, so first you have to relieve the constipation, for which we have many options in the market. Like we have bulk form agents in the with the name of psyllium or isabgol. This is the isabgol available with the same name as isabgol or polyethylene glycol. Isabgol, you have to give the patient to 2 TSF with lukewarm water at the bedtime, or you can give osmotic diuretic, laxative, osmotic laxative. This is that is milk of magnesia or lactulose, that is comes in the market with cremafin or cremafin plus. You can give this 3 TSF at the bedtime. So this is the timing of laxative. You have to ask the patient to take at the bedtime. Once you have given the laxative and he is not responded, you can, and in spite of laxative he is having persistent constipation, you can add one of these drugs, and these drugs are levetiracetam, lenaclotide, or prucalopride. So these are the three drugs available in the market. Lubiprostone available with the Luvol names, and the strength is 8 microgram or 24 microgram. Lenaclotide available in two strengths, 145 or 290, and the brand name is Lignes. These all brands are available in the India market. If you are living outside the India, then you can search with this drug name, that what kind of what kind of brand name you are having in your locality. Prucalopride is something which are available in almost everywhere. The one or 2 milligram in the 1 or 2 milligram strength, and you have to given 4 milligram per day. And the name is Prucent. So once you have given some laxative, if it not work, then add with Prucent 1 to 2 milligram. You will give 2 milligram bleeding for it at least a week initially, and then see the response. If patient responded, continue your percent with for 8 weeks or 4 weeks more with laxative, that become SOS cases. So this is the constipation predominant IBS, and these are the treatment options we have. And the next, if it is diarrhea predominant IBS, then yes, loperamide. This is a very frequent used in the patients. 1 to 2 milligram available in 1 to 2 milligram strength, and the brand name you have Lomofen Plus or Imodium or Lomit. Lumid. So you have to give 1 to 2 milligram per day for at least 12 weeks. Yeah, the duration of therapy is very long, as in the refractory diarrhea or intermittent diarrhea we are usually giving loperamide in SOS basis, but in this case you have to give for quite longer period. In the Indian market, it is Lomefin Plus or Imodium, very easily available everywhere. UDCA is ursodeoxycholic acid. Ursodeoxycholic acid is a good agent to control the allergy. Why? Because studies have shown that in 30 to 35% of cases, this is quite high number of patients, and they have some sort of fat indigestion, in the IBS. So you have to give, you can add UDCA. So till now, once a patient have come to you, if it is constipation, you have to give laxative plus percent. If it is diarrhea, you have to give loperamide with UDCA. This becomes your treatment till now. Allosatran is not routinely used, but if it is severe diarrhea, you can use. The dose is 1 milligram per day. It is available in 0.5 and 1 milligram strength. The name is same, allosatran, so you can give it. So apart from diarrhea and constipation, now comes to the symptomatic relief. This is abdominal pain or bloating. Because patient is always complaining of some kind of bloating. So you can antispasmodic, usually given is SOS basis, but you can give as a regular basis also in IBS, because as we know that this is a chronic disease. So dicyclomine, that is available with mefenamic acid named meftelespas, and easily available everywhere in the Indian market. You have to give it 3 to 4 times a day. Hyoscine is also available, but hyoscine is less commonly used. You can give 0.125 to zero point 0.5. Strength available in the market is same name, 0.125 and 0.25 milligram. Otolinium is a quite good drug in as an anti-spasmodic, because it do two things. It reduce the inflammation. If there is any inflammation in the bowel, it will reduce it. It will decrease the bowel movement also. So when it decrease the movement, it will decrease the frequency also. So otolinium is a good drug named in Menoctil 40, available in Indian market with Menoctil 40. You can give Menoctil 40 for for BD for 4 weeks initially, and then see the response, and then change to the other therapy. Once you have given all these things and you have seen that the patient is not responding, you can add antidepressant. And antidepressant, you have most common we have is amitriptyline or nortriptyline, easily available in the market. Name is Triptoma, Dapranil, Dapsol, etc. The distance is 10 to 25 milligram per day. So in the the role of antibiotics are very unclear, and they are not routinely given, because as you know, the patient is chronic. It is a chronic disease. IBS is a chronic disease. So patient go to the many RMPs or any practitioners. They give them antibiotics, a lot of antibiotics, a different kind of antibiotic, a lot of variety of antibiotics he already taken, and then he will come to the some specialist or some MBBS. And then as we know, the patient is already taken too many antibiotics and the role is not clear, then we don't need any kind of antibiotics. So what is proven is rifaximin. This is the only antibiotic which studies has shown to be effective, and the market, Indian market, it is available as Gmigut or Rifagat. The strength is 400 and 550. So according to the weight, if the weight is less than 60 kg, you have to give 400, and if more than 60, you have to give 550 milligram. That frequency is thrice per day, and at least for 14 days, 2 weeks you have to give it, and then you see the response. And the studies have shown that once you given this frequency for 14 days, it will resolve the symptoms for at least six months in more than 90% cases. Yes, this is a proven fact, and many studies have proved it. So in IBS patient, when patient is very anxious and you want to give some antibiotic, always include Rifagat or Gmigut, whatever available in a locality. According to the weight, you can set the frequency and then see the response. Probiotics can be given, because when patient takes some antibiotics, their bad microbiota is already implanted, and good microbiota is eradicated. So role is controversial, but yes, you can give probiotic to implant, to restore the gut microbiota. And we have many probiotics, but the few common, Derolac Plus or Git Lactovate or Sporolac Plus, these are the common brands available in the Indian market. Fecal microbiota transplantation is the same as we are doing with oral If patient with is not responding to oral probiotics, you can go for colonoscopy where they implant the fecal microbiota and normalize it. So you have tried everything. You have given some antispasmodic. You have cured the constipation, diarrhea, and yet patient is not responding. Now your duty is to refer the patient to the gastro surgeon or gastro physician. So this is your humble duty, because once you have tried everything and the patient is not responding, then you must refer the patient, because there might have something which you are missing. There might something which can be dangerous to the patient, so that can be life threatening. So referral is also a good option when you are practicing in a small level. What when you need to refer the patient once the age is more than 50 years, means there are high chances that he is having any malignancy or hidden malignancy which you are not able to see. The super specialty physician will pick this up. If the patient is having discomfort and you are going the treatment but the discomfort of pain is progressive, means apart from treatment he is taking, the pain is continuously increasing, means there is something which is creating a lot of problem. Third is there is a bleeding also, means when you thinking there is, you have done everything, you have done colonoscopy also, gut is absolutely normal, but patient saying there is minimal bleeding with stool. So that is a red flag sign, and you need immediately refer the patient. If there is an unexplained weight loss, that favors the malignancy. If the symptoms more in night, the patient if symptoms are more in night, that always require a good screening and workup. So that will do that will be done by only gastrophysician. So you will refer the patient. And apart from the, if there are any family history of malignancy, IBD, celiac screw, or the patient saying that my father, mother, or first degree siblings having similar diseases, then also you have to refer the patient. The super specialty physician will handle it very fine. So these are the all points that you need to refer the patient in these cases. So thank you so much. This is the all about the IBS. I want to teach you that in the clinical practice, when the patient come to you, the what treatment you have to give, what options you have, what kind of what how you going to diagnose the patient, how you investigate the patient, and how we approach the patients. In this lecture, this is all I want to tell you. But in my further lecture, I will also cover few of the important diseases and how we're going to treat the patient in a clinic, how become a doctor with confidence. Reading lectures and everything is not the only thing which a doctor needs. Doctor need what you need is confidence, and what you need to be is doctor with confidence. So this is my target is to make you a doctor with confidence. So हमारे साथ बने रहिएगा. Thank you so much.